Before moving on to the other endocrine functions of the kidney, let's briefly talk about the juxtaglomerular apparatus. You can read the details here, but the basic principle is that this collection of cells is responsible for secreting renin, and it does this in order to preserve GFR. This allows the body to maintain kidney perfusion, which is necessary for survival, even at times when blood volume is lower than it should be. Now let's move on to some of the most important aspects of kidney function that students often forget about: the hormones. There are 4 important chemicals secreted by the kidney. 3 of them are endocrine hormones, meaning they act at distant sites. On the other hand, the 4th chemical is a paracrine hormone, which means it acts locally. We'll get to that in a minute, but first let's start with erythropoietin, or EPO. When the kidney senses hypoxia, the peritubular capillary cells release EPO into the bloodstream. This goes to the bone marrow, which then stimulates the production of more red cells. This is a very relevant fact for your exam, since this process can be significantly altered in the context of a renal cell carcinoma. We'll go into more detail about those cancers later on, but just to give you a heads up, they can secrete EPO in an uncontrolled way even if there's no hypoxia, so that one of the first ways they're detected could be an elevated hematocrit. The next important renal hormone is activated vitamin D. Inactivated vitamin D is synthesized in the skin or can be eaten, but the kidney is needed to convert it into its active form. Since you'll hear more about vitamin D in the endocrine lectures, we won't spend much time talking about its function or the role of parathyroid hormone in this lecture. But one important thing you should know is that renal failure can lead to decreased production of vitamin D and subsequent bone problems. This condition is called renal osteodystrophy. The third important renal hormone is renin, which we've already talked about. The 4th hormone relates to a group called prostaglandins. Like we've said before, these are paracrine hormones that act only locally. Specifically, they vasodilate the afferent arterioles to increase GFR. This is also important clinically because NSAIDs, which inhibit prostaglandin synthesis, can lead to vasoconstriction of the afferent arterioles and subsequent acute or even chronic renal failure. Finally, before we get to electrolyte and acid-base disturbances, let's round out our discussion of hormones by talking about which hormones act on the kidney. You'll notice when looking at this diagram that we've already learned quite a lot about renin, about angiotensin II, about aldosterone, and about ADH, or vasopressin. We've also mentioned that parathyroid hormone, or PTH, has direct and indirect effects on the nephron to increase serum calcium. The only hormone left to discuss is atrial natriuretic peptide, also known as ANP. This is the easiest hormone to remember because the name says exactly what it does. It is a peptide secreted by the atria of the heart that causes natriuresis, or excretion of sodium. You can think of it as having the opposite effect of the renin-angiotensin-aldosterone system. When there is too much blood volume, it acts on the glomerulus, among other places, to increase the amount of sodium loss by the kidney, which in turn leads to loss of fluid and lowering of blood pressure. Before we move on, I think it's important to take a step back and just marvel in the glory of the kidney. A lot of students make the mistake of thinking about the kidney as just a filter. Now, it's true, the kidney is a filter, and that's one of its most important functions, but it's also the chief regulator of solute balance for just about every solute in the body. It's the primary force behind volume regulation for the whole body and behind maintenance of blood pressure. And if that wasn't enough, it also has a number of endocrine hormones that affect red blood cells, the gut, and even the strength of your bones. It's pretty crazy, and it makes it clear why some of the renal pathology we'll get to later can be so devastating. Moving on, these next 2 facts are mostly just lists that need to be memorized. When it comes to potassium, a number of things affect the balance of serum potassium by shifting it into or out of cells. These are all logical and straightforward, so memorization is really the fastest way to learn this material. Please remember to come back to this table. As far as electrolyte disturbances, this table lists symptoms that you would expect to see from derangements in commonly measured electrolytes. Again, most of these just need to be memorized. But one thing that's important to mention is the EKG changes that can go along with potassium changes. You will be responsible for knowing these EKG changes on your exam, which are described here and also in the cardiovascular chapter. Now we're almost done with renal physiology. The last big topic to talk about is acid-base physiology. If you want to split hairs, technically, this topic extends beyond just the renal system because it also involves the lungs. But since the kidney is the main driver of acid-base balance, it's best to discuss it in this section. As you probably remember, the normal pH of blood is about 7.4. This is a number that's very carefully regulated by the body. The details of acid-base regulation are way too complicated to include here, but one basic concept you should know is that of buffering. The main buffering system in the blood uses bicarbonate and carbon dioxide. Any excess acid in the blood can combine with bicarbonate to produce CO2 and water, which keeps the pH relatively constant. In the same way, any excess base in the blood can combine with CO2 and water to produce bicarbonate, keeping the pH again relatively constant. Even though there are a number of other buffers, this is the most important for you to know. Also, for the exam, you should be familiar with using the Henderson-Hasselbalch equation for calculations of pH. The Henderson-Hasselbalch equation is used to determine the pH of a solution with buffers, and specifically in this case, a solution that's buffered by bicarbonate and carbon dioxide. This all serves as the backdrop for understanding acid-base disturbances. Let's start off with some terminology. Something ending in osis refers to a process that tends to shift the pH in a certain direction. For example, an acidosis is any process that tends to make the pH lower, and an alkalosis is any process that tends to make the pH higher. However, these words don't directly refer to the pH of the blood, since there can be multiple of the processes that exist at the same time. Another useful distinction is metabolic versus respiratory. Respiratory processes are those that are caused by changes in carbon dioxide exhalation, whereas metabolic processes include pretty much everything else. With those terms in mind, let's look over this table. In each column, the bold arrow indicates the primary disturbance, and the other arrows indicate compensatory responses. We'll go through the specific causes of each of these on the next page, but now let's just think through it in broad strokes. A metabolic acidosis has low bicarbonate as the primary disturbance, and this causes hyperventilation that gets rid of carbon dioxide as a compensation. The reverse of this is a metabolic alkalosis that has high bicarbonate as the primary disturbance, which causes hypoventilation to retain CO2 as compensation. In the case of any primary metabolic disorder, the predicted CO2 value that would be expected can be calculated using Winter's formula, which is shown here. This is a useful formula to know for your exam, and it's pretty simple to use. If you don't like using formulas, you can also just estimate the pCO2. It increases by about 0.7 for every 1 milliequivalent increase in bicarb, and vice versa with decreases. For respiratory conditions, the compensatory response happens in the kidney. The kidney either increases or decreases the amount of bicarbonate that's reabsorbed. One important point is that metabolic compensation in this way takes approximately 24 to 48 hours, whereas respiratory compensation with a change in breathing happens pretty much immediately. In order to really make this information stick, we've got to work through some sample questions. Let's suppose a patient comes in with morphine overdose. You check his arterial blood gas. His pH is 7.25 and pCO2 is 60. In order to figure out what type of acid-base disturbance this is, you just need to follow the algorithm written here. First, look at the pH. Since it's less than 7.4, this is an acidemia. Keep in mind that the ending emia refers to the actual pH of the blood and is different than the ending osis, which refers to a specific process. Now that we know it's an acidemia, we have to figure out if the primary cause is metabolic or respiratory. Since CO2 functions like an acid, a high CO2 level would point to a respiratory acidosis as the primary disturbance. And if you look down the list, you see opioids as listed as a cause, which makes sense. Notice that we haven't talked at all yet about bicarbonate, but we don't even need to know the value in order to figure all of this out. This is the same approach that you should take for any acid-base disturbance. The specifics of each category are in this table. They're all pretty straightforward, and you can feel free to memorize them. One thing that we will point out is a differential for metabolic acidosis. This category is split into two subcategories: metabolic acidosis with an elevated anion gap and metabolic acidosis with a normal anion gap. Remember, anion gap is given by this formula here: sodium minus chloride plus bicarb, and the normal range is approximately 8 to 12 milliequivalents per liter. You will be responsible on the exam for knowing which of these causes leads to high anion gap acidosis and which leads to a normal anion gap acidosis. Again, this material is fairly well suited to memorization. To really help all these concepts sink in, let's do a mini case. Ready? A 65-year-old alcoholic man is brought to the ED unconscious after drinking wood alcohol or methanol. What would you expect his blood pH, bicarbonate, CO2, and anion gap to be? In order to answer this question, you need to know that methanol causes a metabolic acidosis because it gets converted to formic acid in the blood. This means that the patient would have acidemia with pH less than 7.4. Low bicarbonate, since metabolic acidosis is caused by low bicarbonate, and low CO2 due to hyperventilation, which acts as a compensatory mechanism. Also notice that there would be an elevated anion gap since methanol is one of the so-called mud pile causes of an elevated anion gap metabolic acidosis. Great job! Acid-base disorders can be a really difficult concept, and don't feel bad if you haven't mastered it yet. Medical students, interns, and even residents struggle with understanding these types of disturbances. For the exam, the important thing is for you to understand the basic concepts and to be able to apply these concepts to common clinical scenarios like we just did. The best way to do this is to practice, so if you're struggling, try to work through some cases on your own until you get it down. Let's finish off renal physiology with a quick discussion of renal tubular acidosis, or RTA. This is a type of acidosis, so it does apply within the schematic that we talked about before, but it's special because it results directly from the kidney's inability to excrete acid in the urine. The three types are important to distinguish for your exam, and they basically correspond to different mechanisms behind the kidney's inability to excrete acid. You should also know the associated problems with each type. For type 1, it's calcium-containing kidney stones, which we'll talk about more soon. For type 2, it's rickets, which is talked about more in the endocrine lectures. And for type 4, it's hyperkalemia. Alright, that's the end of the renal physio section. As you can probably tell, there's a lot of material here, and it tends to be pretty complicated. Most of the ideas cannot be memorized very well, so when you're studying, it's very important to work through cases, problems, and examples in order to really master the concepts. Now let's move on to renal pathology.